Welcome to the deep dive. Today, we are exploring a really fascinating stack of medical and historical notes on a condition that exists at this absolute, outer edge of human consciousness and movement.
Yeah, it really is at the very edge. It's a state where the mind and the body just seem to completely lose their connection to one another.
Right, exactly. And the mission for today is to figure out exactly what happens when the brain's motor just totally disconnects from its steering wheel. We're going to unpack this 100-year-old medical mistake that, well, it misled generations of doctors.
It's really generations, yeah.
And we'll discover why this terrifying syndrome is actually one of the most dramatically treatable conditions in medicine today. We're, of course, talking about catatonia.
Catatonia, yes.
How?
It's a heavy topic, but so important.
It really is. Okay, let's unpack this. I want you to imagine you are sitting in the driver's seat of a car. You press the gas pedal, and the engine is revving wildly. I mean, it is absolutely roaring, but the clutch is completely broken.
Right, the transmission just won't catch.
Exactly. Because of that broken clutch, the car either just refuses to budge a single inch, or it suddenly lurches forward completely out of your control, smashing into whatever's in front of it. And that essentially is what we are looking at with catatonia.
I love that mechanical analogy, actually, because it captures the core failure perfectly. To really understand why catatonia is so easily misunderstood, we first need to look at what is actually happening in a patient's body and brain.
Right.
Because what's fascinating here is that catatonia isn't actually a single standalone disease in the way we think of, like tuberculosis or chickenpox.
So it's not just a bug you catch.
No, not at all.
Yeah.
It is defined in the medical literature as a psychomotor syndrome. That means it's a cluster of profound abnormalities in movement, speech, and behavior that emerge when the brain circuitry gets disrupted.
Okay.
It's this fundamental breakdown in the normal link between intention, like what a person consciously wants to do, and their actual physical output.
Which, that immediately shatters the most common assumption people have about it. Because when you hear the word catatonic, you almost certainly picture one singular image, right? Someone sitting perfectly still, staring blankly at a wall, completely checked out of reality.
Yeah, the classic statue. But the clinical reality is far more bizarre and, well, complex than just stillness.
Right.
Psychiatrists do not diagnose this based on a general feeling that a patient seems, out of it. They diagnose it objectively by counting very specific physical signs.
Like a checklist.
Exactly.
Yeah.
The DSM-5, which is the standard diagnostic manual, lists 12 specific features for catatonia. To officially make the diagnosis, a doctor has to observe a patient exhibiting at least 3 of those features.
And looking at our sources, I gotta say, these features read like something out of a science fiction novel. We aren't just talking about someone being quiet or sluggish.
No, we are talking about extreme physical manifestations. You have stupor and mutism, sure, which represent the classic total lack of movement and speech. But then you have this phenomenon called waxy flexibility.
Waxy flexibility. That one just sounds so unsettling.
It really is to witness.
Yeah.
Picture a doctor walking up to a patient who is sitting in a chair. The doctor lifts the patient's arm up into the air, twisting it into an awkward, entirely uncomfortable position, and then simply lets go.
And normally the arm would just drop, right?
Right, but instead of dropping their arm, the patient's limb will just stay there, suspended in midair, sometimes for hours, holding to whatever position the doctor left it in, like warm wax.
Oh, wow. Just frozen against gravity.
Exactly. Then there are vocal tics like echolalia, where the patient involuntarily and monotonously repeats the very last word the doctor said, or profound posturing, where they actively hold themselves in strange, rigid, almost statuesque stances.
But then the sources detail the other extreme, too, which completely breaks that whole frozen statue stereotype. Excited catatonia.
Yes. This is perhaps the most crucial misconception we really need to bust today. Catatonia has 2 separate phases. There is the stuporous, frozen form that dominates popular culture, but its mirror image is excited catatonia.
Okay, I have to stop you there because that makes absolutely no sense on the surface. Excited catatonia.
Yeah, it presents as relentless, restless, purposeless, and sometimes violently agitated hyperactivity.
Wait, hold on. How can someone pacing wildly around a room, lashing out at the walls, and someone sitting completely frozen like a statue be experiencing the exact same underlying syndrome? Those are literal opposites.
They look like opposites from the outside, sure.
Yeah.
But neurobiologically, they are 2 sides of the same broken clutch.
Oh, back to the car analogy.
Right. In a healthy brain, your frontal lobes act as a regulatory system. They plan a movement, and they module how much energy goes into executing it. In catatonia, that regulatory connection is severed. The volitional system, the part of you that decides to move with purpose, is offline.
So the brain basically loses its ability to steer the car.
Exactly. And without the steering wheel, the motor system defaults to extremes. In the frozen state, the brain is effectively slamming the brakes down to 100%, just totally locking up the muscles.
And in the excited state.
The brakes have completely failed, and the gas pedal is stuck to the floor, resulting in an endless loop of chaotic, non-goal-directed movement. And the terrifying part is that the underlying malfunction is so unstable that a single patient can literally flip between the rigid, frozen state and the violently agitated state within the span of a single afternoon.
Wow. I mean, think about that from a clinical perspective. If I'm a doctor in a busy emergency room and I see someone in a frenzied, agitated state, my first thought isn't going to be, oh, their motor clutch is broken.
No, of course not.
I'm going to assume they are experiencing a manic episode or maybe a drug-induced psychotic break. I wouldn't realize that underneath all that chaotic movement, their motor control software has completely crashed.
And that misinterpretation happens every single day. And it leads us directly into what is arguably the most unsettling clinical reality of this condition.
The terror within.
Right. When a doctor or a family member sees a patient who is entirely frozen, mute, and staring blankly into space, the automatic assumption is that the patient's mind is as frozen as their body.
Right. People just assume the patient is mentally checked out, completely unaware of their surroundings, maybe lost in some deep hallucination.
But the subjective accounts from the patients themselves paint a much darker picture. A profoundly disturbing one, actually.
Yeah, reading this in the notes was chilling.
When researchers interview patients who have successfully recovered from a severe stuporous state, the overwhelming majority report that they were fully conscious the entire time.
That is just terrifying.
Completely aware of their surroundings, they understood every single word being spoken in the room by the doctors and their families. But they were physically trapped inside their own bodies, entirely unable to initiate the command to move a muscle or utter a sound. The experience is frequently described as a state of acute, intense terror.
Trapped in a frozen, rigid shell while your mind is completely awake and screaming for help. I mean, that is pure psychological horror.
It really is.
But before we move on, I want to make sure you, the listener, understand the difference between this and something purely structural. Because this sounds a lot like locked-in syndrome. How does catatonia differ from a purely neurological condition, like locked-in syndrome, where you're also awake but unable to move?
That's a great distinction to make.
Yeah.
It really comes down to hardware versus software.
Okay.
Locked-in syndrome is a hardware problem. It's caused by physical structural damage to the brainstem, often from a massive stroke. The patient physically cannot move anything except usually their eyes, because the physical nerve pathways carrying the signals have been literally severed by dead tissue.
So the wires have actually been cut.
Precisely. The hardware is broken. There's also akinetic mutism, which gets confused with this too. That's a state of profound apathy, usually from physical damage to the frontal subcortical circuits, the parts of the brain responsible for motivation.
So they just don't want to move.
Right? The biological drive to do anything is simply gone. But in catatonia, the hardware, the brainstem, and the basic structural motor pathways is largely intact. It is a software problem. The intricate neurochemical circuitry that links the will to move with the act of moving is just caught in an endless loop.
Which means if it's a software glitch and the hardware isn't actually destroyed, finding the right way to reboot that software could theoretically fix it.
Exactly.
And knowing that these patients are fully aware, completely terrified, and just waiting for someone to help them, getting that treatment right is a matter of immense urgency. Yet, according to our sources, for over a century, the medical establishment was looking in entirely the wrong place.
The history here is a masterclass in how a single bad assumption can derail medical progress for generations.
Yeah, let's get into the history.
To understand how that happened, we have to look back to the year 1874. A brilliant German psychiatrist named Karl Ludwig Kahlbaum coined the term catatonia. Yes, Kahlbaum. He published a detailed monograph calling it tension insanity. And he proposed something wildly radical for the 19th century. He argued that catatonia was a single distinct independent disease.
Right.
His logic was that regardless of whatever else was going on in a patient's life or mind, if they exhibited waxy flexibility, mutism, and stereotyped posturing, they had this specific disease.
So Kalbaum essentially nailed the physical description right out of the gate. He saw the pattern clearly.
He really did. But his classification didn't stick.
Why not?
His theory was completely bulldozed by the most influential psychiatrist of the next generation, Emil Kraepelin. Kraepelin was obsessed with categorizing mental illness into neat, overarching buckets.
As they were back then.
Right. In 1899, Kraepelin took Kalbaum's highly specific concept of catatonia and forcefully folded it into his own massive umbrella diagnostic category, which he called dementia praecox.
Which eventually became known as schizophrenia, right?
Exactly. A few years later, in 1908, another psychiatrist named Eugen Bleuler renamed it schizophrenia, and he cemented the error.
He kept it trapped in that box.
He did. Kraepelin and Bleuler unilaterally decided that catatonia was not an independent syndrome. It was merely a subtype of schizophrenia. And this created a massive structural blind spot that became a diagnostic dead end for psychiatry.
For literally 100 years.
For roughly the next 100 years, almost every medical student and psychiatrist in the world was trained to believe that the word catatonic simply meant a particularly severe, late-stage form of schizophrenia.
So what does this all mean? Let's ground this in a medical analogy. Imagine if medical school spent a century training every doctor on Earth that a fever is strictly 100% of the time a symptom of a chest cold.
Right, only a chest cold.
So if a patient walks into a clinic coughing and sneezing, the doctor immediately checks for a fever. But if a patient comes in holding their abdomen in agonizing pain from a ruptured appendix, the doctor never even bothers to grab a thermometer because their textbooks explicitly state that fevers only happen with chest colds.
It's a perfect analogy.
Because of this exact kind of conceptual blind spot, generations of doctors walked right past patients with severe depression, mania, or autism and missed their catatonia entirely. They just didn't see it because the patient didn't have schizophrenia.
That historical tragedy played out in hospitals all over the world every single day. It took decades of modern empirical research to finally force the psychiatric establishment to course correct.
And that didn't really happen until much later.
Right. In the late 20th century, researchers like Max Fink and Michael Allen Taylor began conducting rigorous epidemiological studies. They started using standardized rating scales instead of just relying on older textbooks. They started screening everyone.
Everyone in the hospital.
And they found that catatonia was showing up all over the hospital. Depending on the screening scale used, they found it was present in anywhere from 5 to well over 10% of all acute psychiatric admissions.
And when they looked at the data, the vast majority of those patients did not have schizophrenia.
The data was undeniable. They proved it was actually showing up far more frequently in mood disorders, like major depressive disorder and bipolar disorder.
Wow.
This sheer weight of evidence eventually forced the field to rewrite its own rules. In 2013, the architects of the DSM-5 finally tore down Kraepelin's old structure. They decoupled catatonia from schizophrenia and reclassified it as what is known as a specifier.
Meaning it's a diagnostic tag you can attach to almost any primary condition. You can have bipolar disorder with catatonia, major depression with catatonia, or, even autism with catatonia.
Exactly. That reclassification was a monumental victory for diagnostic accuracy. And we cannot overstate how crucial this is because it wasn't just a matter of getting the paperwork right. Classifying this syndrome correctly is quite literally a matter of life and death.
Because if a doctor assumes a patient has severe schizophrenia and treats their catatonia with standard schizophrenia protocols, the results can be fatal. So let's get into the mechanics of how we actually pull someone out of this state. If a patient is trapped in this frozen, terrified software loop, what does the actual intervention look like?
The frontline treatment is something called the lorazepam challenge, and it is widely considered one of the most striking, almost miraculous bedside interventions in all of medicine.
Okay, set the scene for us.
Imagine a busy, chaotic emergency room. A patient is brought in who has been entirely rigid, mute, and staring at the ceiling for 3 days. A doctor will administer a very specific dose, usually 1 to 2 milligrams of lorazepam, either intravenously or through an intramuscular injection.
Okay.
And then the medical staff simply waits and watches. In a substantial majority of genuine catatonia cases, the patient will show visible, dramatic improvement within a matter of minutes to a few hours. The rigid muscles will suddenly relax. The patient might blink, look around, sit up, and return to completely fluent-oriented speech as if they just woke from a spell.
Okay, here's where it gets really interesting, and frankly, where my brain just starts to reject the logic of this entirely. Lorazepam is a benzodiazepine. It is a very heavy, very potent sedative.
It is.
You give benzodiazepines to calm people down, right? To stop panic attacks or put
Yeah.
them to sleep before a procedure. If I have a patient who is already completely frozen, totally mute, and practically unresponsive to the outside world, giving them a heavy sedative sounds completely backwards.
That does sound backwards.
Logically, injecting a sedative into a frozen person should just push them deeper into a coma. How on earth does a sedative wake someone up?
It is an incredible, beautiful paradox, and your confusion is exactly why this condition was misunderstood for so long.
Yeah.
To make sense of it, we have to look at the leading neurobiological theory, which is the GABA hypothesis.
Okay, GABA.
Right. GABA is a major neurotransmitter in the brain, and its primary job is inhibitory. It calms down neural activity. It is the brain's braking system. The hypothesis suggests that catatonia reflects a severe localized deficiency in GABA receptor function within certain intricate motor circuits of the brain.
Meaning the brakes are failing.
Yes. Because those receptors aren't functioning, the inhibitory signaling is completely out of balance.
Wait, let me make sure I follow this. The brain's braking system is failing, which causes the engine to rev uncontrollably. And the body's response to that internal chaos is to just completely jam the clutch and freeze up.
That captures the dynamic perfectly. The brain is actually in a state of hyperarousal and chaotic overactivity. It is desperately starved for inhibitory signals to organize all that noise.
Okay, so the brain is screaming on the inside.
Exactly. And benzodiazepines like lorazepam work by heavily enhancing GABA activity. By flooding those specific motor circuit receptors with the massive inhibitory effect they are starved for, the drug quiets the chaotic noise.
Oh, wow.
It acts almost like a software reset switch. The excessive disorganized signaling is calmed down, the transmission re-engages, and normal voluntary movement and speech can suddenly flow again.
That is just fascinating. The sedative doesn't put them to sleep. It quiets the internal noise enough for their actual willpower to regain control of their muscles.
Yeah.
Though the sources do note that the GABA hypothesis isn't the absolute final word in the science, correct?
No, the brain is rarely that simple, and research is ongoing. While the GABA hypothesis brilliantly explains why lorazepam works so effectively, other neuroscientists point to heavily dysregulated dopamine and glutamate signaling.
Because glutamate is the exciter, right?
Right. Glutamate is the brain's main excitatory neurotransmitter, and dopamine is crucial for movement initiation. When these chemicals get thrown out of balance, particularly in cases linked to Parkinsonian states, the motor system can just seize up. No single unified theory perfectly maps every single case of catatonia yet, but the lorazepam intervention remains the absolute gold standard.
This raises a really important question, though. We know how to fix it when we spot it. But what happens if a doctor doesn't know the patient in front of them is catatonic?
That's the nightmare scenario.
What if a patient comes into the ER in a mute, agitated state, and the doctor, perhaps suffering from that 100-year hangover of Kraepelin's bad training, assumes it's an acute schizophrenia breakdown, and they administer standard schizophrenia drugs instead?
Because the standard treatment for severe acute psychosis usually involves heavy antipsychotic medications.
Right.
And that is exactly where the fatal mistake occurs. If you give a strong antipsychotic to an undiagnosed catatonic patient, you risk triggering a catastrophic multi-system medical emergency.
Because antipsychotics work by blocking dopamine receptors. And if dopamine is essential for smooth motor movement, blocking it in a patient whose motor system is already completely jammed is like, well, it's like throwing a wrench into a broken gear.
The results can be devastating. Left untreated or exacerbated by antipsychotics, standard catatonia can rapidly mutate into something called malignant catatonia.
And that's the lethal one.
It is a life-threatening crisis. The patient's autonomic nervous system goes into meltdown. They develop soaring, dangerous fevers. Their blood pressure and heart rate swing wildly and unstably. Their muscles become locked in a state of extreme lead pipe rigidity.
Lead pipe rigidity, wow.
And because those muscles are tense and starved of oxygen for so long, the muscle tissue actually begins to break down and die off. This releases toxic proteins into the bloodstream, which clogs the kidneys, a deadly condition known as rhabdomyolysis.
So their body is essentially destroying itself.
They can develop blood clots, aspirate fluid into their lungs. It's catastrophic. Before the modern use of benzodiazepines and electroconvulsive therapy, or ECT, the historical mortality rate for malignant catatonia was roughly 50%.
Half of all patients who progressed to that state died, simply because their motor system locked up and destroyed their bodies from the inside.
Yes. And modern medical science now widely recognizes that a highly feared, historically mysterious condition called neuroleptic malignant syndrome, or NMS, which is a severe, sometimes fatal physical reaction to antipsychotic drugs, is essentially just a drug-induced form of malignant catatonia.
So, by giving an antipsychotic to try and help a patient they mistakenly thought had severe schizophrenia, a doctor could unwittingly precipitate the exact fatal crisis they were trying to prevent.
That is why correctly identifying the signs of catatonia and treating it with lorazepam or ECT instead of dopamine-blocking antipsychotics is one of the most critical diagnostic pivots in medicine.
Okay, so we know that giving the wrong psychiatric drug can trigger a deadly crisis. But what happens when the catatonia isn't caused by a psychiatric condition at all? Because you mentioned earlier that the DSM-5 made it a specifier that can attach to medical conditions too.
This is one of the most vital, rapidly evolving frontiers in modern medicine. Catatonia is frequently a symptom of an underlying, purely physical medical illness. It is the body's distress signal. The most famous example of this in recent years is a terrifying condition called anti-NMDA receptor encephalitis.
This is the exact disease at the center of Susanna Cahalan's incredible memoir, Brain on Fire.
Yes, her story brought this into the public eye, and rightfully so. She was a healthy young journalist who suddenly descended into paranoia, erratic behavior, and eventually a profound, unresponsive catatonic stupor.
And the doctors were completely baffled, right?
Baffled, it turned out her immune system had gone rogue. She had developed an autoimmune disease where her own antibodies were crossing the blood-brain barrier and violently attacking the NMDA receptors in her brain.
And for you, the listener, to understand why that matters, NMDA receptors are critical communication gateways in the brain. They are heavily involved in memory, learning, and motor control.
When her immune system attacked those receptors, it effectively shut down the communication lines in her brain. Catatonia was the hallmark physical manifestation of her brain being actively under autoimmune siege.
I mean, think about why this matters so intensely in a real-world scenario. Imagine you have a loved one, a healthy young person, who suddenly goes completely blank, stops speaking, and starts holding their arms in bizarre postures.
It's every parent's worst nightmare.
If a doctor in the emergency room just writes them off as having a sudden, severe psychiatric break, that young person could be locked in a psychiatric ward indefinitely, pumped full of the wrong drugs, when what they actually need is life-saving immunotherapy like steroids or plasma exchange to stop their own immune system from eating their brain.
The stakes couldn't be higher. Misdiagnosing a physical encephalitis as a primary mental illness delays the exact treatment needed to save the patient's brain from irreversible damage.
Yeah.
And this diagnostic confusion stretches into other highly sensitive medical fields too. Take autism spectrum disorder, for example. In the early 2000s, researchers documented a phenomenon sometimes referred to as autistic catatonia.
Right, we saw this in the notes.
This involves a severe, rapid deterioration that can emerge in adolescents and young adults with autism, characterized by a sudden loss of speech, severe motor freezing, and behavioral regression.
But because it happens to patients who already have an underlying autism diagnosis, doctors and even parents often just shrug and assume, well, it's just the natural progression of their autism getting worse.
Which is an absolute tragedy. There is intense clinical debate right now about whether this regression is actually the exact same neurobiological syndrome as psychiatric catatonia.
And if it is,
then it's not an inevitable permanent decline of their baseline autism. It is a recognizable, highly treatable acute medical event. But because of diagnostic overshadowing, where doctors attribute everything to the pre-existing autism, the catatonia frequently goes completely untreated.
and according to her stack of research, it isn't just autism or rare autoimmune diseases. Catatonia is hiding in plain sight in intensive care units too.
Oh, absolutely. Especially during the height of the global pandemic, when ICUs were overflowing with severe COVID-19 cases, astute clinicians started recognizing catatonia in critically ill patients.
Just amidst all the chaos.
Right. In high-stress ICU settings, patients frequently develop delirium, a general fluctuating disturbance of consciousness, attention, and perception. The clinical reality is that catatonia and delirium can co-occur in the same patient, or one can be very easily mistaken for the other.
Because they look so similar on the surface.
Exactly.
Hmm.
The problem is that general internal medicine doctors and critical care staff are rarely trained to screen for waxy flexibility or mutism.
So they walk past a bed, see an unresponsive patient on a ventilator or recovering from a severe systemic infection, and they just assume it's the general fog of critical illness. They completely miss the fact that the patient's motor clutch is jammed.
They miss the fact that the patient might be fully conscious, terrified, and that the medical team could potentially wake that patient up and restore their ability to communicate with a single, inexpensive dose of lorazepam.
It really is a staggering journey when you step back and look at it all. We started with this terrifying, almost unbelievable mechanical disconnect. A brain trying to move a body that absolutely refuses to obey, leaving a fully conscious person trapped in a frozen shell.
It's wild to think about.
We uncovered a 100-year diagnostic blunder where the most influential minds in psychiatric history shoved this syndrome into the schizophrenia box, effectively blinding generations of doctors to what was sitting right in front of them in the waiting room.
Generations of lost time.
And we explored a condition that is highly, almost miraculously treatable with something as simple as a common sedative, but utterly fatal if a doctor misreads the signs and gives the wrong medication.
If we connect this to the bigger picture, the core value of unpacking all this neurobiology and history is understanding just how immensely high the stakes truly are in clinical observation.
Right.
Catatonia sits at this bizarre, high-risk crossroads of mind and body. It is a psychiatric syndrome that is frequently the very first warning sign of a lethal underlying medical emergency, like an autoimmune attack.
The distress signal.
Exactly. Yet it remains one of the few conditions in all of modern psychiatry with a fast, dramatic, and often completely reversible response to treatment. Recognizing it changes the entire trajectory of a human life. A patient labeled as stubborn, non-compliant, or just severely depressed in a busy, overwhelmed emergency room might not be a lost cause.
They might just be stuck.
They might just need a single correct diagnosis and a simple injection to reverse the crisis in a matter of hours.
Which leaves us with something really important to think about. If generations of highly trained, brilliant doctors could look right at a severely depressed patient or a rapidly regressing autistic teenager and completely fail to see their catatonia simply because their textbooks told them that symptom only belonged to a completely different disease, well, what other obvious, highly treatable symptoms might the entire medical field be completely blind to today just because they aren't looking in the right diagnostic category? Thank you for joining us on this deep dive. We'll catch you next time.